Hello, everyone. My name is Yoav Kainan, and I'm the clinician scientist, infectious disease specialist, and scientific director of the National Collaborating Center for Infectious Diseases. I would like to welcome everyone to this webinar on monkeypox infection prevention and control, which is a part of a webinar series on monkeypox hosted by the NCCID in partnership with Public Health Agency of Canada and the Association of Medical Microbiology and Infectious Diseases Canada. I would like to first acknowledge that the NCCID is located at University of Manitoba on Treaty 1 territory and on original land of Anishinaabe, Cree, Oji-Cree, Dakota, and Dene people, and homeland of the Métis Nation. Let us acknowledge the harms of the past and dedicate ourselves to actively working towards reconciliation through collaboration with Indigenous communities. Now let me introduce our speaker for today, Dr. Yves Lantin, who is an infectious disease specialist and medical microbiologist, clinician scientist. He's the chair of Infection Prevention and Control Unit at the Jewish General Hospital in Montreal. Dr. Lantin is also a member of the Quebec C. difficile surveillance program and a member of the Quebec Provincial Infection Control Committee. He's an associate professor at McGill University and a member of AMI Canada. Dr. Lantin, I will now turn on the mic to you.
Thank you very much, Yoav. Good afternoon, everyone, or end of the morning for those in on the West Coast. And thank you for inviting me to present on infection prevention and control consideration associated with monkeypox. So if you're like me, you probably, during training, you probably learn about very hypothetical situation in which you would maybe see a case of monkeypox in your practice, but this disease was unheard of in Canada until very recently. So the likelihood is that if you ever come to see a case in your practice in the following days, you may have questions regarding how to protect yourself, how to disinfect the environment afterwards, and most likely you never got the chance to really learn these notions when you did your training. So I think that we're going to take 30 to 45 minutes today to present the current situation in terms of infection control, consideration related to monkeypox, and also give tips for clinicians to make sure that they protect themselves and other patients. So we're going to start now. Quickly, my disclosures. I have some funding from the CIHR. Also, I think an important disclosure is that I am not affiliated with the Public Health Agency of Canada. I'm a clinician, a researcher working at the Jewish General Hospital in Montreal. But I will be presenting, I will be relying very heavily on the recommendations from PHAC throughout my presentation. One thing I'll try to give you today is also not only to present you bluntly, these are how you should handle a suspected or confirmed case, but also try to give you some perspective regarding the question, how contagious is monkeypox? How worried should I be if I've been exposed to a case? Is it really airborne, or is it more a question of extra precaution that we're taking? I think these are the kind of risk assessment notions that are important for you to do some risk assessment. So these are the objectives, but I think I just summarized them in a few sentences already. So we'll start a bit of background, I think. Here you see beautiful electron microscopy micrographs of monkeypox, which are brick-like huge viruses. And I think in order to understand really the infection control, we need a bit of background regarding the situation right now. So monkeypox used to be a rare infectious disease, only identified for the first time in 1958. It is caused by the monkeypox virus, which is a pox viridae, an orthopox, in other words, exactly like smallpox or vaccinia, cowpox, which we use to vaccinate against smallpox, or also molluscum contagiosum, for example, which is also due to a pox virus. It's a double-stranded DNA enveloped virus. For those of you who do infection control, you usually know that enveloped viruses are easy to destroy with disinfectant. It will be the case, and this is what you'll see today in the slides, but it has a very low lipid content. And this is key to explain why this virus can survive for so long on fomites and remain infectious for long periods on inanimate surfaces. It used to be endemic to Central and Western African countries. There are mainly two clades, the West African clade and the Congo Basin clade. And the current cases in Canada right now, and outside actually in Europe and the United States as well, are linked to the West African clade, which, by the way, usually causes less virulent disease with a lower case fatality rate of approximately 1%. The current, I would say, multi-country outbreak of monkeypox was first notified on May 13, 2022. So merely 2 months ago only in the UK, United Kingdom. The first case was reported in Canada on May 19th. And since then, most, but not all cases have been among patients who identified as gay, bisexual, or men who have sex with men. As of July 8, 2022, the most recent data from IPAC, there has been 375 cases in Canada, mainly in Ontario and Quebec, but also some cases in British Columbia and Alberta. And these numbers keep increasing. So it is likely that there will be additional cases in Canada before we contain the outbreak. In terms of classic signs and symptoms, usually the disease is a disease due to a characteristic rash. We'll see multiple slides in the multiple pictures in the next few slides, but also a prodrome of fever, lymphadenopathy, sore throat, flu-like symptoms that can last 1 to 4 days. So the classical presentation is a prodrome of 1 to 4 days that is followed by the characteristic rash. The rash here, you've probably seen a few pictures so far, even in the news. The rash goes through multiple stages from a macule, which is a flat lesion that you cannot palpate. I don't have a picture here. Followed by a papule, and then even a pustule that will umbilicate. These lesions will then crust over. The crust will dislodge from the skin, and a healthy layer of skin will appear underneath. The rash classically is centrifugal, meaning that it starts on the face, and then it will spread on the palms and on the hands and the legs, including the palms and the soles. Can also involve the mucosa, the conjunctiva or the cornea, and the rash takes a long time to heal. It can last up to 4 weeks before healing completely, this rash. This is the classic presentation of monkeypox. The current presentation is a little bit different, and I think this is what the clinicians have to be aware, because it has infection control impacts. That the rash currently tends to be more often localized on the genital and perianal area. Often lesions will start there instead of starting on the face. And the rash may be localized only in the genital area, for example. The prodrome can also be mild or completely absent. So the disease can be confused easily with an STI, and that probably led to a lot of delay in recognition of the outbreak, the current multi-state outbreak. These are examples of lesions of the rash that were published by the CDC very recently. You have the link down there to show you. But you see that some of the rash can look very, very unspecific, some of the rash lesions. This one here, you see a bit more of a pustule with an umbilicus in the middle. A rash on the palm of the hand also is typical of monkeypox. And here you see some pustule lesion. I would say very few lesions on the body of lesions that will umbilicate with time. So what is the infectivity period of monkeypox? Well, the incubation period usually is from 6 to 13 days with a range of up to 21 days. This will be important when we start considering post-exposure prophylaxis with a vaccine, for example. Fortunately, because the incubation period is long enough, you still have time. If you vaccinate rapidly enough after exposure, you still have time to either prevent the disease or make it milder. So the contagious period starts with the onset of symptoms, either the appearance of the rash or the prodrome, if there's a prodrome before that. And it lasts until, and this is very important, contagiousness lasts until the lesion scabs and heals completely over, which means that the lesion has to fall off and a new healthy skin has to form underneath. So contagiousness can last up to 2 to 4 weeks. This is important because usually in infection control, contagious rash-wise, typically it's zoster and varicella, for example, where contagiousness ends once the lesions have crusted. Once varicella lesions have crusted, patients are deemed non-infectious anymore, but this is not the case for monkeypox. So if you see these pictures here from the UK, all these lesions would be still being contagious, including the very last one where it has scabbed over, because there's still a piece of scab over it. And that piece of scab here would still be considered contagious. And I'll show you data to convince you that it is the case. Would still be contagious. So that even that stage is still contagious lesion. How does person-to-person transmission occurs? I will not go too long into a zoonosis aspect of the disease where humans acquire it from animals, but what interests us today is the person-to-person transmission. So person-to-person transmission can occur from direct or indirect contact with the skin, lesions, or body fluids, either through the broken skin or exposure of your mucosas. You can also acquire it through fomites. And I think the same way COVID for us was a moment where we realized, oh my God, aerosolization might be very important for this new disease. Here you have to change your mind and think, oh my God, fomites are very, very important for this disease. And we have to be careful with fomites. Because there's really a potential of transfer through surfaces. So that's very different from COVID, which we've been trained for the last 2 years, where we almost virtually thought that fomites were not important. For monkeypox, it is very important. Or also, it can also be acquired the disease through respiratory droplets. As for sexual transmission, no clear case has been documented so far. But sexual partners do have direct close contact, so it could be simply during a sexual activity, skin-to-skin transmission. How contagious is the disease? Well, person-to-person transmission seems to be uncommon, and this is important also. The R0, which is how many secondary cases you have when you have a primary case of monkeypox, is between 0.3 to 0.6. So this is much smaller, much lower than smallpox, for example, where the R0 was estimated to be 5 when it still existed in the world. Just to give you an example of what it means, in the 1980s, there was a study of secondary attack rate within household in the DRC, so in the Congo. And the attack rate within a household was 9% only. And keep in mind that those households in the 1980s, they were described in the paper as very small huts, where it was very difficult to isolate one household member from the other household members. And mainly transmission occurred between children. So the children under the age of 4 were at higher risk of having secondary attack rates. And it was felt to be because it was harder for them to isolate from the index case. So even in those small huts in the 1980s in the DRC, the secondary attack rate was within the family was only 9%. And for non-household contacts, meaning contact in the village but not within the household, the attack rate was only 4.5%. So again, this risk of transmission, I think, is important to understand the risk assessment of transmission within the healthcare system. And it is also much lower than the other grade pox virus, which was smallpox, which had a secondary attack rate of between 37 and 80%. How about airborne transmission? Well, currently, the consensus is that it is unknown if airborne transmission can occur with monkeypox. However, and this is important, there is no evidence of long-range aerosol transmission. I know what you say, you're going to say absence of evidence is not a proof of absence, of course. But just to give you an example, in the paper I just presented you previously regarding the attack rate within household in the DRC in the 1980s, they also look at the risk of the neighboring hut of acquiring monkeypox when there was a case in a hut. So, and the attack rate was 0%. So no one in the neighboring hut would acquire monkeypox if they didn't have direct face-to-face contact with the index case. So it really goes against the concept of airborne transmission. So why are we still concerned about airborne transmission then? Well, it's because, of course, monkeypox is a pox virus and we all fear smallpox. Smallpox was really a proven airborne transmitted disease. From the studies conducted in the 19th century and the 20th century before the 1970s when it was eradicated, they had very strong evidence that smallpox could be transmitted over air currents to a distance of up to 1 mile from the index case. So there have been multiple cases reported. So of course, because monkeypox is a bit similar in terms of structure to smallpox, people decide to go a bit more cautious, and what if it could be airborne just like monkeypox was. If it ever occurs, it is definitely not the primary mode of transmission, however, for monkeypox. As I said previously, fomites is more important, however. There's not a lot of data regarding the risk of fomite transmission for monkeypox, but we have a lot of data with the surrogate marker of monkeypox, which is cowpox, vaccinia. There's a lot of data regarding this because it's been used as a surrogate for all the studies that people were conducted on disinfection or survival of pox viruses in the environment. Instead of using smallpox at the time, people were using vaccinia virus, the cowpox virus instead. And we know that from cowpox studies, we know that pox viruses are very resistant to drying. They can survive on dried skin crusts, on dried serum, on dried blood. They can survive for very, very long time. Vaccinia virus can survive over 7 months at 4 degrees Celsius, and can survive for more than 3 months on wool, so on textiles. And historically, of course, smallpox was known to remain contagious on clothes for up to several years. So here, just a study to show you that it's really true. It's not only a tale of folklore that it can survive for a long time. Here you have an in vitro study of how long the vaccinia virus could survive on different surfaces. So they inoculated the surfaces, glass and steel and cinder block and carpet with 10 to the 7 plaque forming unit of vaccinia. And 14 days later on glass, they could recover virtually all of it. 2 weeks later, it was all still alive on glass. And even a lot of it was still alive, could be recovered and still infectious 6 weeks later, 42 days later. So how about infection control then? What in the healthcare setting? So given all these things, well, sadly, we still don't know a lot about infection control for the current outbreak in high-income countries, because the disease has not been seen very often outside of the areas of endemicity. Because of that, we're not too sure how we should handle in terms of infection control in high-income countries. There's also the fear that the atypical presentation, the current atypical presentation I presented previously with a more of a genital area presentation for the rash, the absence of prodrome, suggests that it also raises the question, has the virus mutated? And could that influence actually its transmissibility? So still, given these considerations, most recommendations right now would be deemed as level of evidence of expert opinion only. But the guiding principle is to protect healthcare workers and also prevent the establishment of endemicity in Canada. Because whereas smallpox had only one potential reservoir, which was human, smallpox was incapable of infecting animals. Monkeypox can definitely infect a wide range of animals. We'll speak about it. So of course, a theoretical fear, it's hard to quantify that fear, but one of the theoretical fears would be that this monkeypox outbreak that currently transmit between humans could one day cross-transfer again to an animal and start creating a reservoir within animals in Canada, which would make containing the disease almost impossible. Once you have an animal reservoir, it's very difficult to control the disease within a country. So what's the risk of healthcare workers acquiring monkeypox? Well, there is numerous instances of healthcare workers acquiring monkeypox in endemic areas. However, when you read those case reports and case series, what you see is that the transmission occurred very often either before monkeypox was recognized. So the patient showed up with a rash, for example, and doctors thought it was varicella when actually it was monkeypox. Or because people knew it was monkeypox, but didn't have the proper PPE to protect themselves against the case. Or it was non-healthcare related exposure, meaning that people will, for example, healthcare workers during their break will play with kids who have monkeypox, or during lunch breaks will also be exposed. So that these cases would be deemed as healthcare associated, of course, because they occur within the confines of a hospital, but they would not be they're probably less likely to be relevant to our reality in Canada. As for healthcare worker acquisition in high-income country, we could find only a single case of acquisition in higher income country and of a healthcare worker acquiring monkeypox, and that occurred in the UK. In that case, it was a healthcare worker who changed the bed sheets of a patient who had active lesions while wearing gloves and apron, but without a medical mask or N95 respirator. And that person who spent then a lot of time in the room, cleaning the room, changing the bed sheets, but without a mask, without a respirator, with gloves and gown, that person acquired monkeypox afterwards. So overall, PHAC quantifies the risk of transmission to healthcare workers as being low at the time in Canada. So how do you prevent acquisition then? Well, there's various guidelines. And here I only have 3 guidelines to show you. There's the PHAC guideline. There's also a guideline that has been produced by the World Health Organization and also the CDC. And there are others, European ones, and there are even provincial ones as well. It's impossible for me to present you all these guidelines. So what I've decided to do is actually what I'll be presenting you mainly are the PHAC guideline. These are the national ones. There might be some provincial small differences, but they're generally in line also with these. And when it's relevant, I will also present some recommendations from WHO and CDC, but these will be clearly marked in the slides with a little logo of the WHO or the CDC to say, this is a recommendation that's specific to these guidelines. When nothing is mentioned, it's the PHAC recommendation that I'll be presenting. So in terms of infection control measures, in terms of PPE, if you suspect a case, what you need is the use of contact precaution, which means you need to wear gloves, you need to wear a gown, a long sleeve gown, of course, with cuffed sleeves. You need also to protect yourself, ocular protection, either a face shield or goggles. Both are acceptable from PHAC's recommendation. And also you need to implement airborne precaution, but very special one. You need to wear an N95 mask that needs to be fit tested and seal checked. I'm sorry, I said very special one. I mean, it's airborne precaution. You need to wear N95. Of course, these are added to routine practices, which means hand hygiene, point of care risk assessment, respiratory hygiene. Of course, these additional precautions are added to the standard precaution. I put in gray here a footnote regarding a specific recommendation that only can be found in WHO's guideline, which is that they recommend dedicated footwear that can be disinfected. But this recommendation I put in light gray just to acknowledge that WHO does recommend it, but it cannot be found in neither the PHAC or the CDC recommendations. As for donning and doffing, just keep in mind that they recommend donning prior to entering the room, and to doff, remove the PPE prior to leaving the room, except for the N95 respirator. The idea is to leave the contaminated equipment as much as possible in the room to prevent aerosolization. If you shake this equipment that it's contaminated, at least it's going to be in the patient's room. Do not reuse respirators. They're single use. I know that since COVID, people have been using respirators as single use mainly, but it used to be a time, for example, for tuberculosis, where you could reuse a respirator multiple times. You could just keep it in your pocket and put it on when entering the room, and leaving the room, you put it back in your pocket. So that's something that holds for TB, but not recommended at all for monkeypox. Don't forget to do hand hygiene after PPE removal. As for hand hygiene, either soap and water or alcohol-based hand rub sanitizer are both acceptable in terms of hand hygiene method. So how do you do source control also? How do you decrease contagiousness of the patient? The PPE I've presented first because I suspected that's what would interest you the most. But source control is much more powerful strategy to prevent transmission in hospitals. So in terms of source control, of course, you ask the patient to do hand hygiene, ask him to wear a well-fitting procedure mask. No need for N95 for patients, just a procedure mask, well-fitting, however, and cover the lesions. Patients should be wearing a long sleeve gown if possible, clothes or bandages except during the examination. One tip that the CDC gives is simply, if lesions are on the hands, simply to ask the patient to wear gloves. At least the hands are covered, the lesions are covered. As for patient placement, and this is maybe a place where guidelines tend to disagree between them. In Canada, IPAC recommends the use of an airborne infection isolation room, which means a negative pressure room, if it is available. If it's not available, you can use a single patient room and close the door simply. This is a bit different. The CDC, for example, says that the special air handling negative pressure is not required for monkeypox, except if there's aerosol generating medical procedure, intubation, for example, then you need a negative pressure room. So this is different from IPAC that says you should use a negative pressure room if it is available. And as for WHO, they have recommendations that maybe apply a bit more to low-income countries, where they suggest actually to use a well-ventilated single room and use a negative pressure room only if varicella is still a possibility. So this is an area of where the consensus is not quite there in terms of recommendations between organizations. Visitors, you should restrict visitors to those only necessary for care or on compassionate ground. And as for cleaning and disinfection, well, good news at least, virtually anything kills monkeypox. It survives a long time on surfaces, on fomites, but any disinfectant will easily get rid of it. Here you have this study that shows numerous disinfectant, and you see that they were all very active, very rapidly against monkeypox. It's an enveloped virus, easy to kill. For quaternary ammonium, 15 minutes achieve 4 log reductions easily. So it is a relatively easy pathogen to kill, providing that you do reach it where it survives, which means on the fomites. Generally speaking, whichever hospital grade housekeeping, cleaning, and disinfection protocol product you're using right now, if it has a DIN, a drug identification number from that is approved from the government of Canada, it will be effective against monkeypox as well. You have to clean all the surfaces that has been touched, of course, the high touch areas, doorknob, light switch, call bells. They recommend to dedicate the equipment to the single patient, not to share equipment between infected and non-infected patient. On discharge, you discard all the disposable item. If an item is not disposable, but you cannot disinfect it, so think electronic equipment, for example, that would be more difficult to disinfect. The suggestion from PHAC is simply to discard it, not try to reuse it, and change the privacy curtains upon discharge. This is an area where you might be interested in speaking with your housekeepers and environmental services department in your institution, is that you need to make sure that they use the proper PPE when cleaning and disinfecting the environment, which means that they need to wear glove, gowns, but also ocular protection and N95 respirator when disinfecting the environment in their patient's room. A recommendation from CDC and WHO, I think it's just not mentioned by PHAC, but it just makes sense. Usually we don't do this in hospitals. It is that you have to use damp mopping. Do not do dry dusting, dry sweeping. This will only increase the risk of aerosolizing the crust, the skin cells, the fomites, and increase the risk of healthcare worker acquisition. How do you handle then also the linens, the towels, the clothing, the bedding? You need to wear the appropriate PPE when you collect and bag all the linens. Be careful when you don't remove them by shaking the sheets, that will only aerosolize them. Keep in mind that the only case of secondary acquisition in a high-income country occurred in a healthcare worker who was changing the bedding without wearing respiratory protection. So this is something that has occurred in the past in the UK. So make sure that the healthcare workers wear proper PPE. Do not shake the bed sheets, but rather lift them carefully and roll them. That's the best way to contain the virus within the bed sheets. You should place all the laundry material in a sealed bag and clearly identify them for transport to the laundry service. You can wash and dry only in the regular medical laundry services will be able to handle the virus. So there's no special cleaning or drying procedure for contaminated linen. The only thing I would draw attention to is that WHO also says that even once at the laundry service, the workers who handle the laundry in the laundry service should wear full PPE when handling that laundry. So glove, gowns, and N95 and ocular protection. It is an area that is a bit more gray regarding PHAC's recommendation. It is not as explicitly mentioned. The PHAC simply mentions that you have to be in the laundry service. You have to make sure that the linens, contaminated linens, don't get into contact with the skin or the clothes of the workers. WHO goes one step further by saying you should be wearing full PPE when handling it in the laundry until you put it in the washing machine. If you're in private practice, you can use a standard washing machine on warm cycle, 70 Celsius, hot water cycle. With detergent, will inactivate the virus. And you can dry completely in a regular commercial dryer, will also get rid of the virus. Medical waste wise, you should be handling them only as per regular medical waste as per PHAC recommendations. So in a leak-proof plastic bag with in a solid case, sealed garbage bin, or double bagged. And disposal of it as per PHAC is just as per local jurisdiction. There's no particular handling recommendations right now from PHAC. As for patient transportation, of course, you try to keep your patient in the dedicated room as much as possible. Patients should not be using public transportation. He should be wearing a procedure mask when traveling outside of his or her room and cover all the lesions when leaving the room. How do you prevent acquisition? I think that one thing that is important, and today's presentation will help, is to know that monkeypox now is present in Canada, close to 400 cases since May. So it is a possibility. So you have to add the monkeypox to your differential diagnosis. either when you see genital lesions, genital ulcers, when you see a disseminated rash as well. Many other diseases can cause these clinical presentations, but now you have to add monkeypox to your differential diagnosis. You have to be aware that atypical presentations do occur and are reported, and that the best way to orient your diagnosis is to elicit a good travel history, sexual history, or history of contact with other people who had similar lesions. That's the best way to suspect that that diagnosis is a possibility. If a healthcare worker has been exposed, and many of you probably have questions regarding this, I have to say, I don't work with Public Health Agency of Canada. They are currently, the guidelines are almost ready to be published. But there are currently no official recommendations from PHAC regarding exposed healthcare workers. One thing though that is obvious is that because acquisition occurs after touching lesions, if you don't touch a lesion with your bare hands, which actually is just good practices, right? Basic practices says that you should never be touching non-intact skin with bare hands. So don't touch lesions with bare hands. If you wear gloves, and if you also wear a procedure mask when you see all the patients, which is probably the routine right now in your hospital, in your practice because of COVID. So if you wear your procedure mask and you wear gloves when examining skin lesions, most likely you will not be deemed as a high-risk exposure, even if that patient turns out to have monkeypox. So that should be reassuring. And of course, as soon as the new recommendations will come out, we'll be able to give you more information. As for WHO, by the way, they define exposure as any situation where healthcare workers have cared for a patient without the appropriate PPE. But when healthcare workers have been exposed, they are not excluded from work. So good news for you, you will most probably not be excluded from work for 21 days, which is the incubation period for monkeypox. You should notify occupational health and safety, however, and what they recommend right now is active surveillance of the symptoms for up to 21 days after the last exposure, with temperature measurement twice a day, and also an interview by occupational health officers prior to reporting to work to make sure that the healthcare worker does not work while sick. As for post-exposure prophylaxis or vaccination, if you go on the CDC website, you'll see that the Americans have come up with levels of exposure from high, moderate, low risk of exposure, and they recommend post-exposure prophylaxis for the high and the medium and some medium exposure risks. But currently in Canada, we're still lacking these recommendations. Hopefully they'll be coming soon. As for WHO, they say that this should be done in the context of research only. So I just want to spend a few minutes on infection control at home, because there were a lot of questions about this prior to assisting to the meeting. So keep in mind that most patients with monkeypox right now will have mild to moderate disease, and will probably, if they have no risk factors like immunosuppression, for example, or who will probably be sent home to take care of themselves at home. They will not be hospitalized. So how do people need to isolate at home? CDC mentions, and I think this is something that will be done on a case-by-case situation here in Canada, that you have to make sure that the home is an adequate place for the person to isolate, which means that you have to be careful that there's no young children at home, because the children are less likely to follow the isolation recommendations, or pregnant women, or immunosuppressed people, or even people who have skin disease like eczema, atopic dermatitis, because these individuals are more at risk of having very severe monkeypox if they acquire it. So we have to make sure that home is an adequate place to for the person to isolate. And this will be done usually with in collaboration with the public health authorities of the province where the case is discovered. It is possible to isolate at home. They recommend a private room with a private dedicated bathroom. If you don't have a private washroom that can be dedicated to the case, then the washroom will need to be disinfected all the time after every use by the case of monkeypox. The use of a well-fitting medical mask when around others, which is very similar to what we did for COVID, and maintain good hand hygiene and respiratory etiquette. Covering all the lesions, source control is always good practice, and you have to refrain from sharing all the potential fomites with the other people who live in the house. As for sexual contact, as I said, it's not clear whether the disease can be spread through sexual contact, but because there's been case reports of DNA being present in the semen, for example, for many weeks after the disease, the recommendation is to abstain from sexual contact while infectious, of course, contagious, but also to use a condom for 3 months after monkeypox. A quick recommendation about pets and animals. Again, here the main concern is reverse zoonosis, where we would be a bit worried that potentially monkeypox could again jump the species barrier and start infecting mammals in Canada and create a new reservoir. So they recommend that you should not have pets at home if you isolate, if you have monkeypox. Have someone, a neighbor, a family member take care of your cat or dog. Dogs are not known to acquire pox viridae, but cats can definitely acquire the vaccinia virus. And of course, the rabbits also can acquire vaccinia virus. A concern is squirrels. So a lot of squirrels right now in Canada, in the cities. And so and they're rodents, and rodents are usually susceptible to pox viruses. So there's some theoretical concerns that monkeypox could establish itself within the squirrel population. And this is why, even though PHAC does not go very deeply into that topic, the CDC mentions that you have to be careful, the individual in monkeypox has to be careful to handle his or her trashes very responsibly and make sure that the trashes do not get in contact either with the domestic animals, the pets, but also the wildlife to protect them from monkeypox, which is a theoretical risk. Waste management at home also has to be very responsible. So here, this picture of an open trash bin with PPE being disposed freely into. This is not how you're supposed to handle trash. Remember, fomites are potentially very contagious in monkeypox. So the recommendation is to use the dedicated linen trash can. And every time you discard PPE, you don't put it in the trash can directly. You put it in a bag that you tie, and then you put that bag into the trash can to make sure that to limit the risk of aerosolization of the contaminated equipment. As for cleaning, you need any house cleaner is probably sufficient to disinfect the environment. The main challenge is to clean and disinfect surfaces that are shared after every use. So it's easier if you can isolate alone at home, but if other people live in your house, you'll need to clean the shared space after every use. If you have lesions on your hands, using gloves when disinfecting the environment is a very good idea. And also, and this isn't a suggestion from the CDC, but I think that makes a lot of sense. They say, even if you're isolating alone at home, regular disinfection of your environment is probably a very good practice to prevent buildup of monkeypox virus in the environment because it can survive for so long. So cleaning the environment very often is a good way to make the environment less contagious. One of the tricky areas is vacuuming. The recommendation is not to vacuum at all unless your vacuum has a HEPA filter. So it's more the higher end, more expensive vacuums that do have HEPA filters. So many individuals will not have the proper vacuum to disinfect the environment. Another challenge are all the furniture, upholstered furniture. This furniture could, in theory, get contaminated if the patient with monkeypox sits in that sofa, or it's not a sofa here, it's an armchair. It could contaminate the textile that could remain infectious and contagious for numerous weeks. So the recommendation is to cover them, cover your upholster, remove your carpets, cover your upholstered furniture to prevent contamination. And you can use steam cleaning also if you don't have a HEPA filter on your vacuum. Terminal cleaning is also probably something that would be overlooked. We don't do such thorough cleaning after someone recovers from infectious disease, but the CDC does recommend that at the end of the infectious period, you have to do a thorough cleaning of all the areas that may have been touched by the person with monkeypox, which means also cleaning the inside of the drawers and even cleaning the inside of the fridge. So a very deep, thorough cleaning awaits the person to celebrate the end of the contagious period. So this is a summary of all the recommendations. I'm sure you do have some questions, and many of the questions you have are probably real questions in the sense that there's still a lot of uncertainties regarding many aspects of contagiousness of monkeypox. So is there infectivity, pre-symptomatic infectivity, for example, that was so common in COVID? We're still not sure. We don't think so, but we're still not sure. What are the routes and the relative contribution of the various routes of transmission for human to human transmission? Is there really a potential for reverse zoonosis, transmission back to animals, or is it just theoretical sci-fi scenario? How do you deal with healthcare workers who have been exposed in terms of post-exposure prophylaxis? And how stable is the virus in the environment? It's something that we know a lot about vaccinia virus, a bit less about monkeypox. So these are just a few of the questions that will still need to be answered in the future. And these are a few references, and that will cover my presentation for today, and that leaves us some time for questions.
Thank you very much, Dr. Longten, for the fantastic presentation. And you've answered the tremendous amount of the questions, but there are some that recur. So, and maybe a repetition, but at least will allow us to summarize some of the recommendations. So we'll try to go through some of the questions that are from our Eventbrite questions that appeared before, as well as the questions that are in the chat box. And we'll try to balance that. So there are a couple of questions still about what is the role if the transmission is through genital secretion, how long are those infectious, and which genital secretions play a role in transmission? And how important is that transmission compared to the transmission because of the face-to-face, close, intimate contact?
Yeah, the answer to this question is we don't know for sure. There has been, I'm aware of publications where they recovered DNA of the virus in the semen after the patient has, when someone had active monkeypox. But is this semen infectious? Finding DNA doesn't mean necessarily that the virus is infective, right? So is it infective? It's unclear. And does it apply to other secretions like vaginal secretion? To my knowledge, this is still an area that is where the answer is still unknown. And as for the relative contribution of these routes, this is also a very good question. Classically, sexual transmission was not deemed to be the main route of transmission. But again, because the clinical presentation is a bit different this time compared to the classic monkeypox from endemic areas, it is not impossible that actually even the mode of transmission has changed. So even though we don't know the answer, it actually is a very, very valid question. Maybe sexual transmission is a more relevant route of transmission. Certainly we'll know more about it in the upcoming months.
Thank you very much. Another question is regarding the transmission through venues where potentially transmission can occur through fomites, etc., that are related to hotels, restaurants, resorts, sport activities. Any documentation of transmission through those thus far in this epidemic, and what's the risk?
I wish we had a public health authority representative here who do all the contact tracing of the cases that occur in the community. Of course, my presentation was more focused on the healthcare system. In the community, my understanding from discussions I had with public health authorities is that the vast majority of people had direct exposure to the lesions. So unexplained transmission through fomites seems to have not been very, very well documented so far in the current outbreak. But then again, keep in mind that the secondary attack rate within households, and the paper I presented you in the 1980s in the DRC was only 10%, which means that even with what we assume was very heavy contamination of the environment within the household, the transmission was relatively rare to other family members. So if you then compound the fact that in a restaurant, for example, or a bar, exposure is probably much lower as well. People are dressed, you don't have direct contact. There are reasons to understand that if it occurs, it's probably a relatively rare event.
Thank you. In terms of household, and I know that there are lots of unanswered questions there, when there's no opportunity for separate bathroom, what would you recommend in terms of minimizing risk of transmission there?
Yeah, so it's to minimize contamination by the person who uses the bathroom, the monkeypox case, as much as possible, and then using only dedicated equipment as much as possible. Anything that will not be dedicated will need to be disinfected thoroughly afterwards. So there's no magic solution to this problem. Should not share towels, of course. Bring back the towel to the bedroom afterwards, to the isolation area, to prevent the risk of don't leave it in the bathroom again. But there's no other easy solution to that situation.
And if you could summarize again, thank you very much for that answer, the recommendation for discarding garbage linen in a monkeypox client home. This is recurring here.
Yeah, so the public health authorities of Canada are not very explicit on the handling of the garbage at home. You could, in theory, just discard it through regular garbage. I know some researchers are a bit more worried of the wildlife getting in contact with the garbage. So this is why some people are not super comfortable with that recommendation, but this is the current recommendation right now in Canada. And I think it makes sense also because it's a very theoretical risk. So I guess it's a balance between feasibility and also and it's a risk benefit as evaluation that is done.
Thanks for that, Yves. In terms of the airborne versus just a closed room, the difference between Health Canada and CDC recommendations, can you tell us a bit from your experience in Quebec and what's your take on that?
In Quebec, the cases we've had, well, in my institution, the case we've had no problem convincing the authorities to put in a negative pressure room. Once you have one, it's hard not to use it for a case of monkeypox. But I think that the fact that other organizations like the CDC say that a negative pressure room is not required is definitely reassuring and highlights the current uncertainty regarding the potential for airborne transmission. But as I've said as I presented in my slides, it is more of a theoretical consideration. There is no hard evidence that the virus can be really airborne on long distances. And this is also reassuring for people in private practice, for example, or outpatient clinics who probably don't have negative pressure room. It's the fact that PHAC says you should use a negative pressure room if you have one, but if you don't have one, simply put the patient in a single patient room, close the door, and that will be okay. And I think it's very reasonable.
Thank you for that. And would you change those recommendations if the individual has lesions that involve the respiratory tract, oral, perioral, or tracheal, where we may anticipate higher burden there?
Yeah, I think that becomes a case-by-case question if there are oral lesions. Keep in mind that the negative pressure room is definitely recommended. If it's mandated if you do an aerosol generating medical procedure. So if you have the impression that the patient may be aerosolizing high quantity of virus, you should be using a negative pressure room.
And now for health.
It's the same recommendation for the CDC, by the way. CDC says negative pressure room for AGMPs. There's no way around it.
Yeah, that's been agreed with all other as well. In terms of occupational health perspective, a healthcare worker that has been exposed, what is the current recommendation in terms of isolation? If a healthcare worker is symptomatic, then what is the recommendation? How to do this?
So exposed individuals right now, no organization is recommending removing from work. Everybody can work while surveilling their symptoms. If they develop symptoms, then they have to stop working immediately and they need to be worked up. If they're positive, they'll need to be isolated for as they become a patient, right? And they'll need to isolate until not contagious anymore, which may be all the way up to 2 to 4 weeks.
Fair enough. And in terms of individuals who share a room, roommates, or have contact for care, or were in a room with a patient that subsequently developed monkeypox or was diagnosed, what is the recommendation for isolation for those?
You mean for a patient? A patient,
yes, a patient who was shared a room prior to the diagnosis.
Because the disease does not start, infectivity doesn't start prior to disease onset. You don't need to isolate the exposed patient. You just need to track for the appearance of symptoms and isolate as soon as the patient develops symptoms. So it can always be tricky, of course, because there's a question of declaring the exposure to the patient, and incubation can be long. Incubation can be up to 21 days. So symptoms could occur after discharge for the exposed patient, but there's no need to isolate prior to the appearance of symptoms. They do need to be aware, though, because they have to track they have to know that this little pimple is not acne, it's actually monkeypox. So they need to be aware to look for skin lesions.
Yves, are you able to comment on the transport of samples and in terms of how to transport samples to the lab in terms of that and how to dispose of sampling?
They're very good questions. Actually, I didn't create my presentation to touch the topic of sampling, shipping, testing, because I believe this will be the topic of another Monkeypox Monday.
Okay, so we will leave that question to the one that specifically deals with lab testing and also disposal of that. Thank you for that. In terms of vaccination, and I know this is again not the topic of the conversation, but exposed healthcare workers, what have you done with them in Quebec in terms of offering vaccination?
So vaccination is not something that we've done for exposed healthcare workers so far that I'm aware of for the cases I've been aware of in my private practice. Just keep in mind that anyways, public health authorities have control over the vaccines, and any situation where you would deem that a healthcare worker would need to be vaccinated post-exposure would have to be discussed with public health authorities because they're the ones who control the the stock of vaccines. I could imagine that a high-risk exposure in an immunosuppressed healthcare worker, for example, I could imagine on situations like these, you could probably, even though no official guidelines have been published so far by IPAC, I could imagine by discussing with public health authorities, there could be some common ground that could be found to vaccinate. You have up to 4 days to vaccinate, and even some people say up to 14 days after exposure to vaccinate, to either prevent the disease or to make the disease milder. But this will be on a case-by-case situation. Currently, we haven't vaccinated any healthcare worker exposed so far.
And if you've described the transmission from a patient to healthcare worker in one scenario, has there been the reverse and a transmission from healthcare worker to patient so far in this outbreak?
Not that I'm aware of. Not that I'm aware of, but it is a very, very valid question for which we'll need more guidance, because individuals who acquire monkeypox could be healthcare workers themselves, who could in theory expose patients. But I'm not aware of any case of transmission or of any guidance regarding management of these cases as well. So it will be a case-by-case scenario if it occurs in your practice.
And I think that the last question that we will take on for this question period is in terms of maybe two questions. In terms of the duration of protection, so you said that the condom use 12 weeks was the recommendation. Does that include the time of incubation, or this is from complete healing of any lesions in the genital area if they were?
If my memory is correct, I think it's for 3 months from the onset of the disease, if my memory is correct. But you know, it's you got me with that question.
Very good. Okay, and I think that most of the questions, there's one that relates to the temperature of washing and disinfecting laundry. Any recommendation if you can't do a warm cycle, or it's 70 degrees and that's all?
The recommendation, depending on the organization, is hot water. You use hot water. You have to assume that's probably going to be roughly 70%. But remember that there's going to be soap in there as well, and there's just the dilution effect of the water. So hot water cycle with a hot drying in the drying machine will take care of and activate the virus. Okay.
I think that I still see some questions, but they're repeating some of the themes. I want to thank Dr. Longten for the in-depth conversation of both infection control in the hospital and healthcare setting, as well as at home. It's a big task, and you it gave a fantastic presentation. Thanks for answering all the questions. The webinar will be available shortly at the NCCID website for those who want to watch it, and also the presentation will be made available upon request. I would ask you to please fill your evaluation of the webinar, and also in that let us know what other webinars in the topic you're interested in, so we can plan our next activities to answer the wishes of the audience. Thank you very much, Dr. Longten, and thanks for the organizers for this webinar.
Thank you.